physicians and Dr. Krishna, Dr. Das, my all senior colleagues. Today is a pretty important administrative topic, that is medical or clinical audit. This is a very important aspect, often neglected, but nevertheless it should not be ignored. So what is clinical audit? Basically, it is the process of reviewing of the delivery of care to identify deficiencies so that they may be remedied. So I am repeating, it is the process of reviewing of delivery of care to identify deficiencies so that they may be remedied. It may be defined as medical audit. What is medical audit? It may be defined as peer review for evaluation of medical care through retrospective and concurrent analysis of medical record. And peer review, you all know that it is review by the peer group. As in this auditorium, we, the doctors of Central Hospital, constitute a peer group. So if you review something, if this group reviews something, it is known as peer review. So medical audit is defined as a peer review for evaluation of medical care through retrospective and concurrent analysis of medical record. I welcome our new CMD, Dr. Roy. Today's topic is no problem. Now we can safely say that is CMD. No dispute. So the topic is medical audit. It is the administrative topic. What is the primary aim of medical audit? To improve the quality of healthcare services rendered to the patient. What medical audit is not? We have already told what is medical audit. Then what medical audit is not? It is not a fault-finding mission. It is not a punitive action. It is not an external quality control method. And it is not to be conducted by any professional other than medical profession. That is a wrong concept. We, the medical members of medical profession, can easily conduct the medical audit. In fact, we are the most qualified person to conduct medical audit. Who will carry out medical audit? Definitely medical audit committee of the hospital, constituting medical director, coordinator, hospital administration, representative of all disciplines and nursing disciplines. So they will conduct the medical audit. What are the prerequisites? Good record keeping system should be carried out by fair and impartial professionals, clinician, nursing and other staff, as well as patient anonymity to be mentioned. Initiative should come from within. Purpose should be simple and clearly stated. Intention should be to effect change for the patient. That last line is very important. Intention should be to effect change for the patient. It is not a fault-finding mission. It is just a system within, so that we can improve ourselves. So this is the audit cycle, very important. Measure the baseline, set the standard, then measure practice through data collection and analysis, assessment of performance against standard, identity, opportunity for improvement, suggest change, then implement the change, then evaluate the change, then again either review the standard if required, and then again you can set the standard. So this is the audit cycle. For the benefit of the DNB students, we are discussing medical audit. in a hospital. Medical audit is also important from academic point of view. We can actually get very important clinical data. Methodology. First, we have to select a topic. The topic should be common because it is common or high risk or bears high cost. Should be having local clinical concern or known wide variance in clinical practice. Topic should be well defined, focused and amenable to standard setting. So first we have to select a topic. What we will take for medical audit. Then example of some topics, long or short stay cases, specific disease, specific operations, vulnerable groups, increased incidence of a disease, post-operative infection, complications, all deaths, and last but not the least, we can also audit our OPD prescriptions to see whether we have correctly prescribed something. Setting of standard to be set prior to study, criteria to be based on objective measures. Criteria is an item of care or sure aspect of care that can be used to assess quality. It is a written statement. Example, all patients requiring urgent appointment will be seen that day. That is the criteria. We can do audit on that. All patients with epilepsy should be seen once a year. All patients on oral anticoagulants should have their INR within recommended limits. So these are some of the standards. Criteria should be justified. Target should be set at realistic level for defined patient groups and take into account local circumstances. A target describes the level of care to be achieved for any particular criteria. For example, 98% of patients requesting for urgent appointment will be seen on that day only, whether we have achieved that or not. Secondly, 90% of patients with epilepsy should be seen at least once a year. 100% patients on oral anticoagulant should have their INR within recommended level. So these are some of the realistic targets. Methodology, criteria and target applicable to structure, process and outcome variables. Criteria, structure, process, outcome, staffing of ICU. It should be not less than 1 per 2 occupied beds. If we audit on the structure, this is one of the standards. Then process, PT during surgery, not less than 5% and not more than 20% of average cases. This is the evaluation of process.
PT not transfusion though.
Outcome is definitely case fatality, suppose one outcome, not to exceed 0.1% for specified procedure. So this is one of the outcomes, whether we have achieved that. Setting of standard. Objective criteria are overt, but clinical judgment can be used to answer the question, what was the management of this case? Was the management of this case satisfactory? This is an implied criteria. Use of overt criteria should be preferred. The problem of implied criteria is that important deficiencies in care may be overlooked. If the criteria is overt, that is, it is open, then it is easy to be understood. So criteria should be preferably overt, not covert. Worksheet preparation and methodology administration. It should be simplest for the purpose. Only essential data is collected. Suitable sample size is to be selected. Sample size, there are many methods we know: random sampling, stratified sampling, then systematic sampling, cluster sampling. Any of the methods can be taken to assess the sample size for any audit. Worksheet preparation and methodology administration continued. Probability of bias is to be considered. when bias can occur if there is non-response to a survey, unavailability of certain types of case note, selective referral of certain types of patients, failure of patients to turn up for follow-up. Selective referral, you all know, some patient referred some hospitals. There are some circumstances when patients had to be referred, or sometimes we have to give post facto concurrence, even if there is that facility is available in central hospital. Still, some patient insist that they have to be treated outside. So these are all causing bias of assessment. Tabulation of evaluation, interpretation, efficiency of care recognized, specific solution are proposed. They may not be possible every time. Education impact is appreciated. Affecting change, planned program for change. All staff is involved. Active feedback, and then audit is evaluated. What to check in medical record? What we see actually in audit: completeness and adequacy of the record. Check issues related to the diagnosis, investigation and treatment, referral and consultation, treatment and plan of care with justification, operation whether it was justified, an end result, an administrative lapses for undesirable results, calculation of various statistics. Certain additional questions: why audit? To improve the quality of care. It is an aid to continuous medical education. There is a sense of personal and professional achievement. What are the motives for doing audit? They can be categorized as under professional, social, pragmatic, legal. So this is the chart where we can easily see the motives of any audit, motives behind any medical audit, professional audit, social motive, pragmatic motives and legal motives. Under professional motive, to identify deficiencies, educational need, self-correction and self-regulation. Social motives, to ensure safety of public, to prevent patient from inappropriate or suboptimal care. Pragmatic motives, to reduce patient suffering. That is of course a pragmatic view. And then legal motives, we should be careful about CPA, negligence, malpractice. So if we have a system of regular medical audit, we may face many legal problems because we can say that we regularly conduct audit in our system. Certain additional questions related to clinical audit. What are the key questions to be asked while doing clinical audit? What do we do? Do we do what we think we do? What should we do? Are we doing what we should be doing? How can we improve what we do? How we improve? So these are the additional questions should be asked. What are the benefits of audit? Professional benefits, change in prescribing behavior, updating of clinical knowledge, increasing staff enthusiasm and satisfaction, teamwork. Then patient care and service delivery, improvements in patient care, improved patient satisfaction, better patient feedback. What are the perceived disadvantages? Increase in workload, restriction of clinical feedback, professional threat. What are the barriers to audit? Lack of resources, lack of expertise in design and analysis, lack of an overall plan for audit, relationship problem, organization impediments, disputes between views of clinicians and managers, and time constraints. Last but not the least, I have seen that